30 seconds or 1 minute.
What?
So that people might engage. People will come. Interesting. Okay, that interesting like 1 minute. At the time, most of the people get notification. Now I started like that. Hello, sir.
So hi guys, welcome to this particular session. Today we are here going to discuss about out of the 100 topics, today we are going to discuss 25 topics. The list of the 25 topics I think you might already have received. Okay, so yeah, that's what we are going to do. Shall we start? Okay. Okay, so let's start. The first topic which we are going to talk about is the sutures. Now in the sutures, what you need to understand is that there is something which is called as the needle. Okay, there's something which is called as a needle. Yep, and then what we have is a suture material. So today what you're going to focus is mainly on the suture material. Okay, so what we are going to talk about is this particular suture material. That is what we are going to kind of primarily talk about. Okay, I hope I'm audible and visible to you in a proper manner. Yep, I hope I'm audible and visible in the proper manner. Yep. Okay. Now, let me just address this particular question. Many people keep asking me, is it for neetpg, is it for fmge? So what you need to understand is that it is basically for both. Okay. So the important topics for the neetpg and the fmge are more or less the same. And the knowledge is knowledge. Obviously, it's like in whichever way you ask. Now, you might say that, you know what, sir, how is it possible? You know, no. So the point is that the level of questions are also more or less the same. If you take the fmge paper or the neetpg paper, I always keep on telling this. The only difference is that in the neetpg you have to perform in a much better manner, because your ranking is based on the relative performance between the students and everything. In the fmg you have to just qualify that particular 50% of the marks. So that's the broad only difference. Rest, what you need to understand is that so what you need to understand is that apart from that, the level of the paper, the topics are more or less kind of the same. Okay, 5 to 10% of the topics are a bit more asked in the neetpg, but those are the like the 5 to 10% of the difficult topics. Rest 80-90% of the topics are more or less the same. So I hope you have understood. It is basically for both the neetpg as well as the fmg. Okay, so yeah, let's kind of start. So the first thing what we are going to talk about is this particular suture material. Okay, so what are we going to refer to this? This is what is your suture material. Okay, so if you ask about this particular suture material, what you need to understand is that this particular suture material, this can be either an absorbable suture material or it can be a non-absorbable suture material. So if you talk about this suture material, this particular suture material, it can be either absorbable or it can be non-absorbable. So this particular suture material can be absorbable, or it can be non-absorbable, non-absorbable. Okay, now what you need to understand is that both, like whether it is an absorbable or non-absorbable, both of these suture materials, they can be either natural or they can be synthetic. Okay, so what can they be? They can be either natural or they can be synthetic. Okay, and the same basically goes for the non-absorbable also. It can be either natural or it can be synthetic. Okay, now can you give me an example of a naturally occurring absorbable suture? Okay, can anybody give me an example of a naturally occurring absorbable suture? Yes, the answer to this particular question is catgut. Yes, I'm pretty sure that all of you are answering it as a catgut and the chromic catgut. Okay, so what we have is, we have catgut, and then what we have is a chromic catgut. Okay, so these are the things which we have. Okay, now what about the synthetically occurring absorbable sutures? Can you give me an examples of a synthetically occurring absorbable sutures? The answer to this particular stuff is vicryl. Then we have monocryl, and then what we have is a PDS. Okay, now if we talk about naturally occurring, what you need to understand is naturally occurring non-absorbable suture. So can you tell me about the naturally occurring non-absorbable suture? Here it is silk. Okay, so the silk is the naturally occurring non-absorbable suture, and the synthetically occurring non-absorbable sutures are the nylon, and the proline. Okay, and the proline. Okay, so these are the basic things of the sutures which you need to understand over here. Class till what time? Probably it will go till around 11 o'clock. Around 11:30 the class will basically go. Okay, I hope you have understood now. Okay, so this is the very basics of the classification. So now let's talk about in detail about these particular sutures. Okay, so what did we say about the naturally occurring absorbable suture? Naturally occurring absorbable suture. So what did I tell you about this? What are the things which are included over here? We have a catgut. So can you tell me from where is this particular catgut derived? Okay, so this particular catgut is basically derived from the submucosa. The first thing which you need to understand is it is derived from what? So it is basically derived from the submucosa. Submucosa of what? So it is basically derived from the submucosa of the intestine of the sheep. Okay, so this is basically derived from the submucosa of the intestine of the sheep. Okay, now the question is why submucosa? So can you please tell me why it's only submucosa? So everybody understands what is a submucosa, right? Obviously we have the mucosa, submucosa, serosa, adventitia. These are the different layers of the intestine, right? So why this is derived from the submucosa? So it is basically derived from the submucosa because this particular submucosa is the toughest layer of the intestine. Okay, so it is the toughest layer of the intestine. Okay, and the another thing which you need to understand is that this is derived from the submucosa of the intestine of the sheep. Okay, so it is basically derived from the intestine of the sheep. Okay, now if I ask you that, okay, this is what is an absorbable, like naturally occurring absorbable suture, and it is derived from the intestine as well. So obviously there's a chance that it might go whatever the decomposition and the degradation of this is obviously possible. So here what you need to understand is that it has to be kind of put in some kind of a preservative. Okay, so if I ask you what is the preservative which is going to be used for this, so please try to understand the preservative which is basically used for this is isopropyl alcohol. Okay, what is it? It is isopropyl alcohol. Okay, so I hope you have understood this particular point. So this is basically the preservative which is basically used for this is an isopropyl alcohol. Isopropyl alcohol is used as a preservative for this. Everybody have understood this particular point? Isopropyl alcohol. Okay, now what is the problem with this particular candidate? The problem with this particular candidate is an absorption time. Okay, it is an absorption time. So can you tell me what is an absorption time for this particular candidate? So the absorption time for this particular candidate is how much? Can you please help me with this? Okay, this is around 5 to 7 days. Okay, within 5 to 7 days, this particular suture is completely absorbed. Now, this is a bit of a problem, right? Because, you know, if at all the suture is basically absorbed within 5 to 7 days, then the proper healing of that particular wound might not take place. And in order to increase this particular absorption time, what we came up with? We came up with a chromic catgut. Okay, so what is this particular chromic catgut? Chromic catgut is basically a suture. Over here, what you basically do is you coat this particular catgut with a chromic acid. In this, what are you basically doing is that there is a coating of the chromic acid over the catgut. And what does this do? This basically increases the absorption time. Okay, I hope you're able to understand this particular point. If at all you do this, what is it going to do? It is going to increase your absorption time. Okay, so that is what you need to understand over here. Okay, now everybody is clear till here. Okay, now whether it is a catgut or the chromic catgut, it is an, at the end of the day, it is an absorbable, like a naturally occurring absorbable suture. So how is the process of absorption taking place? Okay, so how is this absorbed? Can you please tell me how is this particular thing absorbed? This is basically absorbed by the process of what is referred to as your enzymatic degeneration. Enzymatic degeneration. Okay, and whenever there is an enzymes which are coming into play, okay, whenever there is an enzymes which are basically coming into play, what is going to happen? It is always going to be an exothermic reaction. Okay, it is always going to be an exothermic reaction, and that is why what is going to happen, there is going to be what you call as a more tissue reaction. So if you compare between naturally occurring absorbable sutures and synthetically occurring absorbable sutures, the tissue reaction is more with this naturally occurring absorbable sutures. Why this is so? This is so because what you need to understand is that the naturally occurring absorbable sutures are absorbed by the process of an enzymatic reaction. Okay, enzymatic degeneration is basically taking place, and that is the reason why what you need to understand is over here the process of the tissue reaction is more with the naturally occurring absorbable sutures. Okay, I hope you have understood this particular point, guys. Yeah. Okay, I hope you have understood this, right? Now, this is about the naturally occurring absorbable. Now, let's talk about the synthetic absorbable sutures. And guys, if you have any doubts or anything, please put it in the comment box so that I'm going to take it up. Okay, right. So let's talk about the synthetic absorbable sutures. Absorbable suture. So what you need to understand about this particular synthetic absorbable suture, the synthetic absorbable sutures, can you please tell me what are the things which we talked about over here? So yes, what we have is a vicryl, we have what we call as a monocryl, then what we have is a PDS. Okay, now what about this vicryl and the monocryl? These have an absorption time of how much? So what is an absorption time for this? The absorption time for the vicryl and the monocryl is around 60 to 90 days. Okay, so what is an absorption time for this? The absorption time for these is 60 to 90 days. That is what is an absorption time for your what you call as the synthetically occurring absorbable sutures. What about the PDS? For the PDS, what is an absorbable absorption time? So absorption time for your PDS is 180 days. Okay, it is 180 days. And that is why this is the one which is referred to as your delayed absorbable suture. Okay, so this is why it is called as a delayed absorbable suture. Why it is like, what is a delayed absorbable suture? It is PDS. Okay, why? Because the absorption time is around 180 days. Okay, and in the synthetically absorbable sutures, how is the process of absorption taking place over here? So please try to understand. The absorption happens via something which is referred to as your hydrolysis, or phagocytosis. Hydrolysis or the phagocytosis is the process of absorption over here, and that is what you need to understand. That is the reason why here the tissue reaction is less. Tissue reaction is less. Okay, I hope you are able to understand this point. Okay, why the tissue reaction is less over here? Because here the process of absorption is basically by the process of hydrolysis or the phagocytosis. Okay, I hope you have understood this particular point. Okay, so that is all about the basic things about the synthetic and the naturally occurring absorbable sutures, which you guys have to understand. Okay, I hope you have understood this point. Okay, now let's move on to the next topic which we want to discuss, which is basic. Okay, what about this non-absorbable sutures? So the naturally occurring is the silk, that's fine. It's non-absorbable, it is always going to be there, and the nylon and the proline are there. So the nylon is the one which is basically used most commonly for the skin suturing. The proline is basically used wherever you want to kind of want it to stay for a prolonged period of time. So it gets used for the hernia surgeries. Okay, this is also used for the vascular surgery. Okay, vascular surgery, hernia surgery. Proline is the one which is basically most commonly used. Now, what about this particular vicryl? Vicryl is also called as a workhorse suture. Okay, it is also called as a workhorse suture because this is the most commonly used suture which you basically have in the surgery. Like during the surgery, the most commonly used suture which is there, it's vicryl. Okay, monocryl is basically used for the subcuticular suturing. Okay, so let's say if at all you want to kind of take a subcuticular suture, there you will end up using monocryl. What about the PDS? PDS is basically used for the hepatobiliary surgeries. Okay, for the pancreatic anastomosis, for the biliary anastomosis, these are the places where you basically use the kind of a PDS. Okay, so I hope you're able to understand what is the source of the vicryl type, sir. So please try to understand, Sai Leela, these are the polymers. Okay, so this is a like these are the polymers which are basically made in the like a factories with the two kind of chemicals or something. Okay, so these are the these are the polymers, copolymers, okay, of the esters and the amides and everything. So this is basically manufactured in the factories. The source is that. Okay, it's not a natural, it is a synthetic, so it is manufactured in the factory. So vicryl is basically a copolymer. Okay, right. So now let's move on to the next topic, which is basically FAST. So anybody, can you please tell me what is the full form of this particular FAST? What does FAST stand for? Can you please help me with this? Okay, so what this particular FAST stands for? Okay, so FAST basically stands for your Focused Assessment Sonography for Trauma. Okay, so what does this stands for? So first thing which you need to understand is the full form of this. So what does this particular FAST stands for? FAST basically stands for okay, so this is Focused Assessment Sonography for Trauma. Okay, what does FAST stands for? This is a Focused Assessment Sonography for Trauma. So what happens is that, first of all, let's try to understand why this is needed. Why this is done. So whatever you do in your life, you always need to have some kind of an aim. So what is an aim of performing this particular fast? The aim of this performing this particular fast is to look for intraperitoneal fluid. Are you understand my point? So what is the aim of this? The aim of this is to look for intraperitoneal fluid. So what do you understand by this particular intraperitoneal fluid? Intraperitoneal fluid basically means that, let's assume that, okay, so you and I, we all have like some amount of the intraperitoneal fluid, but let's assume that after a trauma, okay, so let's say there is a patient who has suffered from a trauma, okay, and after the trauma, if you examine this particular patient and there is an increased intraperitoneal fluid, okay, in these particular patients, what does it tell you? This basically tells you that there is some significant intra-abdominal injury. Are you understand my point? So if at all there is a patient after the trauma, if at all you perform a fast, and on the fast there is a significant intraperitoneal fluid is present in that particular patient, it basically tells you that there is some significant intra-abdominal injury is present in that particular patient. Okay, so why are we performing the fast? Because we want to know whether some significant intra-abdominal injury has kind of taken place there or not. Okay, I hope you have understood this point. Okay, now when we talk about the fast, okay, when we talk about the fast, how do you do that? Okay, so how is this particular fast performed? So this is nothing, this is basically a USG, which is basically done in emergency room, and this is basically completed in 3 to 4 minutes. Okay, in 3 to 4 minutes you complete this particular whatever the test, and that is what is basically done in the emergency room. This is what you need to understand. This is how the basically fast is performed. And how do you kind of perform it? I'll tell you. So what you need to understand is that, let's assume that this is the abdomen, right? This is the coastal margin, this is the abdomen, then what we have is this is what is the pelvis and everything, right? So what you need to understand is that you keep your ultrasound probe at 4 positions. So this is what is in epigastric. Then what we have is right hypochondriac region. Then we have the left, right subcostal or hypochondriac, whatever you want to call it, right subcostal or hypochondriac region, left kind of hypochondriac region, and then at the pelvis. Okay, so keep your probe at these particular 4 positions. Okay, so when you keep your probe at the epigastric region, what are you looking for? So when you keep your probe in the epigastric region, you are basically looking for pericardial tamponade. Okay, so you are trying to rule out pericardial tamponade. When you are basically keeping your probe at the right hypochondriac region, you're basically trying to look for any particular fluid around this liver. When you're keeping it in the left hypochondriac region, you're basically looking for any fluid around the spleen. Then when you're keeping it in the pelvic region, you are basically looking for any fluid in the pelvis. Okay, obviously, right? So this is how you kind of keep the probe at the 4 positions, and this is how you basically perform the FAST. Now, this is separate from the other kind of ultrasound. Okay, so let's assume that I want to get an abdominal ultrasound done. So in that, the radiologist is basically going to report everything. It is going to, he or she is going to report whether the gallbladder stone is present or not, or whether the gallbladder is thickened or not, and all these particular things is going to be reported. But over here, what you need to understand, no doubt that it is an ultrasound which is being done, but the aim of the ultrasound is just to detect the intraperitoneal fluid. All we are trying to see is the intraperitoneal fluid, for which we quickly keep the probe at the 4 positions and we look for the fluid. Now the question is, how much amount of the fluid can be detected by this particular FAST? Okay, so can you please tell me how much fluid can be detected with the FAST? Okay, so the answer to this is, how much amount of the fluid is kind of detected in this particular FAST? How much amount of the fluid can be detected? So what you need to understand is, yes, so it is around 100 to 150 cc. So by and large, it is considered to be 150, but your 11 Willy mentions it as like 100 cc. So yeah, around 100 to 150 cc. This is the minimum amount of the fluid which can be detected by this particular FAST. Now, what is the drawback or the problem of this particular FAST? We were not getting information about the right and the left lung field, and that is why we came up with something which is called as an eFAST. Okay, so what is this particular eFAST? In the eFAST, what you're basically doing is, instead of keeping the probe at the 4 positions, over here you keep the probe at 6 positions. So here the probe is kept at 6 positions. Okay, you understand my point? So probe is basically kept at the 6 positions. So what are these particular 6 positions? The 4 we have already talked about. The 2 additionals is the right and the left lung field. Okay, so over here what you need to understand, in the eFAST, you keep the probe. So probe is kept at 6 positions, which basically include the right and the left lung fields as well. Okay, so I hope you have understood this point. And based on this, what do you have? You have something which is called as a seashore sign, and then what we have is a barcode, or what you refer to as your stratosphere sign. Okay, so what is this particular seashore sign? Can you please help me with this particular seashore sign? So seashore sign is something which is basically present in normal individuals. Okay, in the normal individuals. So for example, let's say you and me. Okay, in the you and me, if at all, let's say we are kind of keeping the probe, what is going to happen? The lungs is going to expand and it is going to come and hit the whatever the rib cage, and then that particular lung is going to go back. Are you understand my point? So this is what is basically referred to as a seashore sign. Like in the seashore, what happens? The waves come, they hit the seashore, and then they basically go back. So this is what is present in the normal individuals. Now, what is this barcode or the stratosphere sign? So this particular barcode or the stratosphere sign, this is basically present in the patients who are having the pneumothorax. So what you need to understand is that air is basically going to create a lot of artifacts. Okay, so air basically creates a lot of artifacts, and because of these particular artifacts, what happens is they basically appear like a barcode or whatever, the stratosphere or something. So barcode or the stratosphere sign is basically what you basically see in the pneumothorax patients. Okay, so as you can see over here, that yeah, so this is what you need to understand. The normal lung, here what you basically get is a seashore sign. In the pneumothorax, what you basically get is a barcode or a stratosphere sign. Okay, I hope you've understood this particular points in a decent manner. Okay, understood? Got it? Now, let's that's all about the FAST and the eFAST, which we have to kind of talk about. Now, let's move on to the next topic. So, what is it? It's the management of the blunt abdominal trauma. Okay, so the third topic which we are going to talk about is the management of the blunt abdominal trauma. Now, what is this particular, so like what you need to understand is that whenever you have a patient and the patient has basically come to you with the blunt abdominal trauma. Okay, so whenever you have a patient who has come to you with a blunt abdominal trauma, what is the first thing which you're going to do? Okay, so what is the first thing which you're going to do? The first thing which you basically do is you check for peritonitis. Okay, so you check for peritonitis. Okay, you understand my point? So if at all this particular peritonitis is present or this particular peritonitis is absent. Okay, if the peritonitis is present, you don't need no other investigation. Straight away you have to kind of go ahead with an exploratory laparoscopy. You understand my point? So if at all there is a patient who is basically coming to you with a blunt abdominal trauma, you need no other investigation. Like if at all the patient is coming to you with a blunt abdominal trauma and the patients are basically having the signs of peritonitis, you need no other investigation. Straight away you have to kind of go ahead with an exploratory laparotomy. Now anybody can tell me what are the features of this particular peritonitis? So let's say there is a patient who has come to you and on examination the patient is basically having tenderness. Does it mean that the patient is having peritonitis? The answer is no. Okay, so please try to understand the signs of the or the features of the peritonitis are what you call as a rigidity and guarding. Okay, you understand my point? So what are the features of the peritonitis which we have? The features of the peritonitis are rigidity and guarding. Okay, if at all on the abdominal examination, if at all you have the rigidity and the guarding, this is what is referred to as the features of peritonitis. And if at all the features of peritonitis are present, then you basically go ahead and do an exploratory laparotomy. I hope you are able to understand this particular point, guys. Okay, that is a very, very basic thing which you need to understand. Now, coming to the actual management of the patients with a blunt abdominal trauma. Okay, so let's assume that there is a patient who is coming to you with a blunt abdominal trauma. Okay, so as I told you that the first thing which you're going to do is you're going to look for features of peritonitis. If at all the features of peritonitis are not present, okay, then what are you going to look for? Then you basically look for hemodynamic stability. Okay, if at all there is a patient who is coming to you with a blunt abdominal trauma, there is no features of peritonitis, the second thing what we have to kind of look for is a hemodynamic stability. Now let's assume that the patient's like the hemodynamic stability is absent. So when do you say that the patient is not hemodynamically stable? If at all the systolic blood pressure of the patient is less than 90 millimeters of mercury. Okay, if at all the systolic blood pressure of the patient is less than 90 milliliters of mercury, this is when you say that, you know what, the patient's hemodynamic stability is absent. You understand my point? So when do you say that the patient's hemodynamic stability is absent? If at all the systolic blood pressure of the patient is less than 90 millimeters of mercury. Okay, in this particular scenario, what are you going to do? The first investigation which you basically do over here is the FAST. What is FAST? We just talked about that, focused assessment sonography for trauma. Okay, so we kind of do a FAST. Okay, so we do this particular FAST. If at all this particular FAST is positive, okay, if at all the FAST is positive, then you take the patients directly to an exploratory laparotomy. You need no other investigation. You don't need a CT scan. You take the patients for an exploratory laparotomy. It makes sense, right? Already the patient is hemodynamically unstable. The FAST is positive. It means that it is trying to tell you that there is some significant intra-abdominal injury which is present. And now you don't need any other investigation. You don't need a CT scan. Straight away you have to kind of take this particular patient for an exploratory laparotomy. But if at all the FAST is equivocal, okay, it is equivocal. Okay, if at all this particular FAST is equivocal, then what are you going to do? You are going to perform a diagnostic peritoneal lavage. Okay, if at all the FAST is equivocal, then you're going to perform this particular diagnostic peritoneal lavage. And if at all this diagnostic peritoneal lavage is positive, then you take the patients for an exploratory laparotomy. I hope you are making I hope you're able to understand this particular point. So blunt abdominal trauma, what is the first you check for the peritonitis. Okay, peritonitis is present or absent. If at all the peritonitis is present, no other investigation needed, even FAST is not needed. You straight away took the patients for an exploratory laparotomy. Now you yeah, so okay, that's fine. But if at all, let's say the peritonitis was not present, then you look for the hemodynamic stability. Hemodynamic stability is absent. It means that the systolic blood pressure of the patient is less than 90 millimeters of mercury. The first investigation which you did was the FAST. If at all the FAST is positive, you took the patients for an exploratory laparotomy. But if at all the FAST is equivocal, then you did a diagnostic peritoneal lavage. The diagnostic peritoneal lavage, if at all that was positive, then you took the patients for an exploratory laparotomy. I hope you have understood this point. Now, the hemodynamic stability, if at all, let's assume that that is present. What do you understand by that is present? It basically means that the systolic blood pressure is more than 90 millimeters of mercury. So if at all the systolic blood pressure is more than 90 millimeters of mercury, that is what you need to understand over here. Okay. Now, if at all, let's say the hemodynamic stability is present, then the first investigation which you're going to perform is the FAST, and then you're also going to perform a contrast enhanced CT scan. And based on the results of this, okay, based on the results of this, okay, so based on this, the physician is going to decide whether the patient is going to be taken for an exploratory laparotomy or the patient is going to be subjected to a conservative management. Okay, so based on this, whatever the treating physician is going to decide whether you have to take the patients for an exploratory laparotomy or you have to take the patients for a conservative management. So based on that, the question which is basically asked to you is that whenever you have a patient with a blunt abdominal trauma, okay, so whenever you have a patient with a blunt abdominal trauma, you get two scenarios. First is hemodynamically unstable and hemodynamically stable. Okay, and then what you basically get is the first investigation, and then you get an investigation of choice. Okay, so these are the things which under these particular headings you have to kind of understand things. Okay, so whenever you have things like this, what you need to understand is that if at all the patient is hemodynamically unstable, what is the first investigation I told you? I told you that the first investigation over here is going to be a FAST. Okay, I've already told you that here it is going to be what you call as okay, so over here what you need to understand, the first investigation is going to be FAST. And what is going to be the investigation of choice over here? It is going to be FAST only, because based on FAST only you decide whether the patients are going to be needed exploratory laparotomy or whatever. Okay, now if at all the patient is hemodynamically stable, the first investigation is going to be the FAST, but the investigation of choice is going to be the contrast enhanced CT scan of the abdomen. Okay, so over here what you need to understand is that over here it is going to be the contrast enhanced CT scan of the abdomen. I hope you're able to understand this particular point. So based on this, you have to kind of understand that these are the questions which can be asked to you. Okay, any doubts, any things which you need to ask over here, guys? Okay, I hope you've understood this particular point. Now, the next kind of a thing what you need to understand over here is okay, right. So now what you need to understand over here is yeah. So let's talk about the next topic, which is basically a pneumothorax. Okay, so next what we are going to talk about is a pneumothorax. So what is a pneumothorax? Okay, so let's look at this particular kind of image first. Okay, so what is this? This is an image of your pneumothorax. Okay, now this is a very important thing. I'm pretty sure that most of you would be kind of aware of these particular kind of x-rays and everything, but I hope you're able to understand that over here what you need to understand is that this particular part of the lung appears more black. Okay, so this is what is going to appear more black as compared to this one. Okay, so this is appearing more black as compared to the opposite side, and that is why what you need to understand is that this is what is a pneumothorax. I hope you are able to appreciate this particular point, guys. Okay, so do not get confused, guys. Okay, I'm pretty sure that 9 out of 10 of you guys would be knowing this particular x-ray, but those 1%, like whatever the 10% of the people who might get confused between the pneumothorax and the other x-rays, please try to understand over here that this particular part of the lung which is appearing more black. So what is this? This is what is your what you call as a yeah, so like the lung has basically collapsed. So collapsed lung, this is what is a collapsed lung, and this is appear more black as compared to the rest of the lung. Why? Because the bronchovascular markings are missing over there. Okay, so because of the loss of bronchovascular markings, that particular part of the lung is appearing more black. I hope you have understood this particular point, guys. Okay, right? So this is what is a pneumothorax. So what is a pneumothorax? Pneumothorax is simply a condition where there is air in the thoracic cavity. Okay, so there is air in the thoracic cavity. That is what is referred to as your pneumothorax. As simple as that. Okay, so what is a pneumothorax? Pneumothorax is basically a patient who is basically having air in the thoracic cavity. Now, how is the presentation of the patient? So if I ask you, how is the patient going to present to you? Presentation of the patients with the pneumothorax, how it is going to be? So let's assume that you are the person who is basically like the in charge of the trauma center, okay? And there's a patient who is coming to you. When you examine this particular patient, how is this particular patient going to come to you? The patient is basically going to come to you in the state of respiratory distress. Okay, so what is the patient going to have? The patients are going to have respiratory distress. Okay, so what are the patients going to have? Patients are going to have respiratory distress. That is the first thing. Okay, now if at all there is a patient who is having respiratory distress, you examine this particular patient. On examination, what you're going to find? You're going to find that the trachea is basically deviated towards the opposite side. So let's assume that there is a history that the trauma has happened to the left side of the chest or something like that. Okay, so trauma has happened to the left side of the chest and the trachea has deviated towards the right side. Okay, so that is what is going to be the history over here. That is, the trachea is deviated to the opposite side. Okay, so trachea is deviated towards the opposite side. Then what are you going to do? So this is what you're going to get on the examination. On examination, this is what you're going to get. What is the next step? Okay, so you are basically going to auscultate. Auscultate. So when you auscultate, what are you going to find? On auscultation, you're going to find that there is an absence of the breath sounds. Okay, so what are you going to find? You're going to find that there is absence of the breath sound. Okay, absence of the breath sound is kind of there. Okay, on auscultation. And finally, you are going to have percussion. Okay, so on percussion, what you're going to find that there is a hyper resonant note. Okay, what you're going to find is a hyper resonant. That is what you're going to find over here. You understand my point? So a patient is going to come to you with a respiratory distress. The trachea is basically deviated towards the opposite side. On auscultation, you have an absence of the breath sound, and you on the percussion, you have a hyper resonant note. So these are the features which are going to help you in diagnosing the patients as a pneumothorax. Now, how do you basically distinguish this from the patients with the hemothorax? So please try to understand, in the patients with the hemothorax, there is going to be the respiratory distress. The trachea will be deviated towards the opposite side. There is going to be the absence of the breath sounds, but on the percussion, what you're going to find is a dull note. So if at all the question gives you this, okay, so if at all the question says that, you know what, there is a respiratory distress, trachea deviated to the opposite side, absence of the breath sounds and the dull note, then what you have a diagnosis? You have a diagnosis of a hemothorax in reference to the trauma. This can also happen in your what you call as pleural effusion, but in with reference to the trauma, you are basically dealing with the hemothorax. Okay, I hope you have understood this point. Now, there are two things. Okay, in the pneumothorax, what you need to understand is that there can be two types. So what are the two types of the pneumothorax? You have something which is called as a simple pneumothorax, and then you have something which is called as a tension pneumothorax. Are you understand my point? So what we have is a simple pneumothorax, and then we have a tension pneumothorax. These are the two things which we have. Now, what is the basic difference between a simple pneumothorax and a tension pneumothorax? Okay, so in the patients with the simple pneumothorax, what you need to understand is that there is a two-way communication of air between the thoracic cavity and external atmosphere. Okay, so in the simple pneumothorax, what is happening, that there is a two-way communication. Whenever you breathe in, the air basically goes into the kind of external atmosphere, and then it again comes back to the thoracic cavity. So there is a two-way communication. What about the tension pneumothorax? In the tension pneumothorax, what you need to understand is that there is a one-way communication. So with every breath you take, the pressure in the thoracic cavity increases. Are you understand my point? So with every breath you take, what is going to happen? The pressure inside the thoracic cavity is going to increase. So this is what is called as a tension pneumothorax. Simple pneumothorax, two-way communication, tension pneumothorax. With every breath you take, what is going to happen? There's going to be the build-up of the pressure inside the thoracic cavity. I hope you are able to understand this particular point, guys. Okay, and how are you going to distinguish it on the basis of your examination? So what you need to understand is that you have a pneumothorax. In this, what did we, what you call, just revise, respiratory distress. Along with this, the trachea is deviated to the opposite side. I told you that along with this, what is going to be happening? There's going to be an absence of the breath sounds. I told you that there's going to be a hyper-resonant note on percussion. So along with this, if at all the patients are also having what you refer to as hemodynamic instability and increased JVP. So jugular venous, jugular veins are basically distended and there is a hemodynamic instability. I understand my point. So if along with all these particular 4 features, if at all you along with this you also have hemodynamic instability and the raised JVP, then you have a diagnosis of what you refer to as a tension pneumothorax. Okay, I hope you have understood this point. Very, 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 very important. Okay, right? Okay, now finally what you need to understand over here is the management. How do you manage the patients? Okay, so let's first talk about the tension pneumothorax only. In the tension pneumothorax, the management, what you basically want to talk about is there's something which is called as an emergency management and there is something which is called as a definitive management. So what is an emergency management? The emergency management is basically insertion of a wide bore needle. Okay, the emergency management is insertion of the wide bore needle, but that is basically different for the adults and the children. Okay, so the question which they basically ask you is that where do you insert this particular wide bore needle in the adults and where do you kind of insert this particular wide bore needle in the children? So please try to understand. In the adults, what you do is you insert a wide bore needle in the 5th intercostal space in the mid axillary line. Okay, so you basically put it in the 5th intercostal space in the mid axillary line. In the children, what you do is here you insert a wide bore needle in the 2nd intercostal space in the mid clavicular. You understand my point? So this is what you need to understand over here. Okay, so in the adults, wide bore needle in the 5th intercostal space in the mid axillary line. In the children, wide bore needle is basically inserted in the 2nd intercostal space in the mid clavicular line. Okay, I hope you have understood this point. And then when we talk about the definitive management, okay, if we talk about the definitive management, so what is the definitive management over here? So please try to understand. The definitive management is insertion of an ICT. You put an intercostal drain in the 5th intercostal space in the mid axillary line. Okay, mid axillary line. Okay, I hope you are able to understand this particular point. Why there is an emergency management over here? Because if you talk about the tension pneumothorax, the patient is in the state of a hemodynamic instability. So this is what is referred to as a emergency situation, right? If you don't manage it within minutes, the patients might not survive. And for insertion of an ICD, intercostal drain, it might take some more time. Okay, and you might not have that much of time to kind of wait because the patients might not survive. And that is why in the emergency situation, you put a wide bore needle. In the adults, you basically put it in the 5th intercostal space in the mid axillary line. In the children, you basically put it in the 2nd intercostal space in the mid clavicular line. I hope you have understood this particular point. For the simple pneumothorax, the management is this only, that is insertion of an intercostal drain in the 5th intercostal space in the mid axillary line, which is basically called as a triangle of safety. Okay, I hope you have understood this particular point, guys. Yeah, everybody understood this point, right? Now let's move on to the next topic. The next topic which we have is a thyroglossal cyst. So any doubts you want to ask me till now, guys? Okay, all okay? Can we move ahead? Okay, so let's move ahead. Yep. So let's move on to the next topic. It's a thyroglossal cyst. Okay. So what is going to be the presentation of the patients with the thyroglossal cyst? Okay. What are they going to give you? They're going to give you that there is a patient who is coming to you with a midline swelling, which is going to move. When is it going to move? So it is going to move with deglutition and with protrusion of the tongue. Okay, so there's a patient who is basically having a midline swelling, and for all this particular swelling is basically moving with the deglutination when the patient swallows and with the protrusion of the tongue. That is what is suggestive of a thyroglossal cyst. Okay, what is it suggestive of? This is what is called as a thyroglossal cyst. And yes, it is right. This is one of the very, very important topics for your FMG exam, guys. Okay, so as somebody's kind of writing in the comment box that this question is surely going to come, I cannot tell you surely, but yes, it is definitely an important topic, very, very important topic for your what you call as a FMG exam. NEET-PG also it is important. It's quite common as well, but in the FMG it is a bit more important. Okay, so as you can see over here, midline swelling which is going to move with deglutination and with the protrusion of the tongue. Okay, now why this particular thing is happening? Okay, why this particular thing is happening? So what you need to understand is that we have a tongue, and from the base of the tongue, what is going to happen? There's going to be a duct which basically comes down. So can you tell me what is this particular duct? This is what is called as a thyroglossal duct. Okay, so a thyroglossal duct basically comes down, and when it reaches to the kind of neck, what happens is it basically gives to the formation of a thyroid gland. Okay, so what you need to understand over here that you have a tongue, and from the base of the tongue, what is happening? A thyroglossal duct basically comes down from the base of the tongue, and yeah, what is this? This is what is your thyroglossal duct. This basically comes down, and you have this particular hyoid bone over here and around this particular stuff. Okay, so thyroglossal duct is basically coming down, and in the neck it basically leads to the formation of your what you call as a thyroid gland. Okay, now after this formation of a thyroid gland, this particular thyroglossal duct, it disintegrates. Okay, it usually disintegrates. Okay, so this particular thyroglossal duct, it usually disintegrates. Okay, but if at all this particular thyroglossal duct, it fails to disintegrate, if at all this particular thyroglossal duct, it fails to disintegrate, this basically leaves behind a swelling which is referred to as your thyroglossal cyst. Are you understand my point? So this basically leaves behind a swelling which is referred to as your thyroglossal cyst. Okay, I hope you are able to understand this particular point. Now, if I ask you, what is the most common location? Okay, what is the most common location of this particular thyroglossal cyst? So please try to understand the most common location of this particular thyroglossal cyst is subhyoid. Okay, subhyoid means a very, very important point, guys. Okay, it's a very, very important point. What is the most common location of this particular thyroglossal cyst? It is a subhyoid, so just below the hyoid bone. So as you can see over here, this is the hyoid bone which we have, and the thyroglossal duct is basically moving around this particular hyoid bone, and most of the times what happens, the remnant of the thyroglossal duct, it basically remains over here, and there is a formation of a cyst. That is the most common location of that. Very, very important. Okay, now I've already told you about the presentation. So how is going to be the presentation? So presentation is going to be of a midline swelling. Okay, what is going to be the presentation? Presentation is going to be a midline swelling, which is moving with deglutination and